Okay guys, here we go. Today what I want to do is I want to talk about diabetic ketoacidosis and hyperglycemic hyperosmolar state. Those are a lot of big words, but hopefully I can simplify those for you. Alright, so let's first attack diabetic ketoacidosis, yeah? Alright, now look, if you break this name down, it's not that hard. First of all, diabetic ketoacidosis occurs in diabetics. Are you going to write that down? Okay, so watch. Usually what happens is it is commonly found in a type 1 diabetic, type 1, so they're insulin requiring. And they are either very sick or they are not taking their insulin, right? So they're not taking their insulin like they're supposed to. Or in some cases, it's actually a combination of those two. So let's talk about that for a minute, right? Let's look at the very sick for a minute. So if you're a type 1 diabetic and you're sick, that means you have dis-ease. Right? If you're sick, you got disease, you have dis-ease. And if you are not at ease, your body is stressed. And when your body's stressed, you get two big hormones released. Acute stress is going to cause the release of epinephrine, and chronic stress is going to cause the release of cortisol. Now, both of these hormones elevate blood sugar in different ways. But regardless of why they elevate your blood sugar, the fact is that it's elevated, right? So if you've studied the epinephrine video on the signs and symptoms of hypoglycemia and also the effects of cortisol on metabolism and how it elevates your blood sugar, you can see that if somebody's sick, their blood sugar is going to go up. And clinically, this is important. So if you're talking to a type 1 diabetic and they've been sick and they've been throwing up and having diarrhea, and you ask them, well, have you been checking your blood sugar? Well, no, I assumed it's low because I'm not eating and I'm pooping everything out. Well, contrary to what they're thinking, their blood sugar is actually probably pretty high. And as we know, we store extra glucose in the form of glycogen, primarily in the liver. So let's look at this a minute, all right? So again, with the simplified two curved lines and a circle, I'm going to try to explain this. Let's use the example where a person is sick and they're not taking enough required insulin. So again, if they're sick, they're going to have the effects of cortisol and the effects of epinephrine, both of which elevate your blood sugar, right? The other thing that cortisol does is it decreases the number and sensitivity of insulin receptors, right? So now you got a problem. Now, when you eat, that glucose load that you eat that gets absorbed from your GI tract, all that stuff gets filtered through the liver. But if you don't have insulin, no insulin, that says insulin. I don't even, all right, you gotta trust me on that. I don't know what that looks like. But I'm telling you it's insulin. If they don't have insulin, then they can't get, what up, G, into the liver. So for all intents and purposes, the liver thinks you are starving. Look, the liver doesn't know that you're a diabetic. All the liver knows is that it ain't getting glucose. And as a result, they think that you haven't eaten in a while, so your blood sugar is low. That's what the liver's thinking. When in fact, your blood sugar is very high, 600, 700, right? That's high. So The liver says, look, my brain needs glucose. So what the liver will do is the liver will take fat and it will convert it to beta hydroxy butyric acid. The other one is acetic acid. And then the last one is acetone. And those three compounds get dumped into the blood in an attempt to give the brain some fuel. So again, the central nervous system brain can only use glucose, but it can use ketones. The problem with this is that the liver and the other cells of the body begin to overproduce these ketones. The brain and central nervous system don't need a huge supply of ketones or glucose. They need a constant supply. So in essence, the liver begins to overproduce those, and what is it dumping into the blood? It's dumping acid into the blood. Why is it dumping acid into the blood? Because the liver thinks you're starving, and so the liver concludes that you don't have any glucose, and the brain needs fuel. The brain can't use fat, but it can use ketones. So the liver makes these keto acids, dumps them into the blood, and that increases the amount of free-floating hydrogen ions in the blood. And because the liver is doing this through metabolism, you are creating a metabolic acidosis. All right, hate to do this to you, but this previous learning stuff, this is where it comes back and bites you in the fatty acid. If you remember the equation you love to hate, you have this situation. So remember, the only thing that really affects pH is the amount of free-floating hydrogen ions. So what happened as a result of you not taking your insulin and your blood sugar being high? Well, the liver started making these keto acids and dumping them into the blood. So the amount of free-floating hydrogen ions in the blood goes up. Well, what do you have floating around in your blood that could grab them and lock them up? And carbonic acid? Yep, you got it, bicarbonate. So that's going to force the equation this way. So when bicarbonate grabs the free-floating hydrogen ions, that's going to reduce the amount of free-floating bicarbonate because it gets locked up in carbonic acid. So if this side decreases, if the bicarbonate decreases, then you have to decrease the amount of CO2. And as we know, the respiratory system controls carbon dioxide. So one of the symptoms associated with diabetic ketoacidosis is called Kussmaul breathing. It is this rapid, deep breathing, and the purpose of that Kussmaul breathing is in an attempt to maintain the pH of the blood. You're making acid at the cell, metabolic acidosis. What's the only system that can compensate? The respiratory system. So this Kussmaul breathing that you see in people with DKA is in an attempt to maintain the pH of the blood. So that's one of the classic signs of diabetic ketoacidosis. Let's go back here real quick to the ketones, right? Acetone is released through the respiratory system. That's why in an emergency room, you may see a doctor or a nurse actually trying to smell the patient's breath. And if it smells kind of fruity, then that's the acetone that's being released, and that can give an indication that this person may be, in fact, in DKA. All right? So now think about it. And again, understanding the functions of insulin is critical. It's absolutely critical. One of the things that's going to happen is with this high blood sugar, without insulin, then triglycerides are going to get dumped into the blood, right? So tons of triglyceride are going to get dumped into the blood, and that's the fuel that's going to become most readily available for the other cells of the body to use. Also, if we look, one of the things that happens is due to the osmotic effect of glucose, right? There is more stuff and less water, so a higher osmolarity in the blood because your blood sugar is so high. And there is going to be low osmolarity in the cells. So water always moves from low osmolarity to high, right? Low osmolarity to high through a selectively permeable membrane, let's not forget. And that's going to draw all of the water out of the cells. And this is happening everywhere, right? So all the cells are having their water sucked out of them by that high blood sugar. And anytime you increase your blood volume, you increase your blood pressure. And that makes you pee more, right? So they're going to be peeing out a lot of glucose, but they're also going to be peeing out electrolytes, right? They're going to be peeing out sodium, they're going to be peeing out potassium, magnesium, the whole 9 yards. So one of the concerns in DKA, if you recall, potassium, it's not found everywhere. You can't swing a dead cat with diabetes without finding stuff that has sodium in it. Potassium's a little different. And if you remember, the blood levels of potassium are 3.5 to 5.5. So when these people are peeing out all that sugar, they're also peeing out potassium as well. So these people can become, in the later stages of DKA, hypokalemic. Now, remember that the insulin stimulates that sodium-potassium pump and takes the potassium that was in the blood and drives it back into the cell, right? But if you don't have insulin, then you don't have that strong stimulator of the sodium-potassium pump. So in the initial stages of DKA, the potassium may in fact be elevated. But due to that massive diuresis, that massive peeing, they can pee out all that potassium. So the things you want to look at when a person comes in DKA, the classic signs and symptoms, right? Let's look at this. And again, if you understand osmosis and you understand the functions of insulin, it makes it pretty straight. Look, you need glucose for your brain to function. Ketones aren't the best. So, and remember, an acidosis decreases neural activity. So they're going to have a decreased level of consciousness, right? They're going to be goofy. They're not going to be wide awake, right? Number two, they're going to have that Kussmaul breathing that we talked about, right? That labored breathing. And that's in an attempt to maintain pH. So that's compensatory due to the metabolic acidosis of dumping those keto acids into the blood. All right, now let's think about it. What's going to happen to their blood pressure? Now watch. As you're drawing out all that fluid, your blood pressure may go up, but you're peeing all that fluid out. So you don't have an unlimited supply of fluid in your cells. So in the late stages, or even as they're going through it, they're going to have low blood pressure, right? Because they're peeing out all that volume, right? And remember that if your blood pressure is low, then your heart rate will increase. So these guys will be tachycardic as well. And remember, look, whoops, watch. 1, 2, 3, 3. Hey, yeah, I should go back to school. Watch. So Their blood pressure is going to be low. They're going to be tachycardic. And remember, all of that fluid is getting sucked out of the cells into the blood and then ultimately into the toilet. So these people are hypovolemic. Their blood volume is ultimately going to be low, and their intracellular volume is going to be low, right? If they're conscious, they're going to be thirsty, right? I mean, that makes complete sense. But watch, their skin is going to be warm and really dry, right? The mucous membranes are going to be dry. Why? All of that fluid is getting sucked out of the cells by the osmotic effect of glucose and then ultimately getting peed into the toilet, right? So they're going to be peeing all the time. Now, if you look at some labs, and I'll put this PowerPoint on there too, because I wrote this thing, so and it says it better, right? I just told you about this. So the clinical manifestations of DKA, right? Decreased level of consciousness, acidosis decreases neural activity, they're going to be hypotensive, skin's going to be warm and dry, they're going to have that Kussmaul breathing, the acetone. Now, because their blood, you're peeing out all that volume, remember, blood is water and the formed elements. And if you're peeing out all that water, the blood becomes much more viscous, and that increases the risk of blood clotting. So if a person comes into the ER or the ICU, these are the labs that you should be looking at. First of all, if it's in a bit, they're in trouble. The first thing you want to get is arterial blood gases, right? And if the pH is less than 7.35, they're in a metabolic acidosis. And the PCO2, or the amount of carbon dioxide floating around in the arterial blood, that's going to be lower than normal if they're compensating, right? So if their respiratory system ain't compensating, then that pH is really going to be in trouble. And their bicarbonate is going to be lower than normal because the bicarbonate is going to be grabbing those hydrogen ions made by those keto acids. And then again, in the early stages of DKA, you may have a low sodium and they may have an elevated potassium due to the inability to stimulate that sodium-potassium pump by insulin. But due to that massive diuresis and loss of glucose and electrolytes in the urine, they can become hyponatremic and hypokalemic. All right, and remember that insulin stimulates that sodium-potassium pump and drives that potassium into the cell. So it's important. That's important, and I'll explain why in a minute. Now, one of the things that they look at too is what's called an anion gap. All right, I'm not going to get into all the details, but basically what they're looking for is these keto acids are negatively charged. So if you have more negatively charged particles than you have positively charged particles, then the only thing that they can conclude is if you're having more negatively charged particles in the blood, that's due to that increase in the keto acids. So one of the labs they'll get is what's called an anion gap. And how you calculate that is by taking the blood level of sodium minus the blood levels of chloride and the blood levels of bicarbonate. So if you take the chloride level and the bicarbonate level and subtract that from the sodium level, you're going to get that anion gap. And the normal anion gap is about 12. But the anion gap is increased in metabolic acidosis, and that is due to the keto acids that are being formed and dumped into the blood. The other labs you want to look for are kidney function. Remember, very important, the kidney can correct any pH disturbance if you live long enough and blood flow and kidney function are maintained. The other thing that you're going to look for too is you're going to do a UA for ketones in the urine. Ketones are dumped into the urine, and that's kind of a quick and dirty test to determine if they're in ketoacidosis. Now, how do you treat this, right? Okay, well, what do? What's their problem? Their problem is their blood sugar's high and they have a relative or absolute lack of insulin. So you give them insulin. And depending on how bad the DKA may be, it may be insulin infusion of insulin, or an IV infusion of insulin. And look, if somebody's blood sugar is 900 at 8 o'clock in the morning, you don't want that blood sugar, 120 at 10 a.m. This is done slowly over time. The goal is to, within about 12 hours, 24 hours, to get that blood sugar under 200, and that they're not dumping ketones in the urine. And if they're not dumping ketones in the urine, they're not producing ketones. And if they're not producing a large amount of ketones, then the pH of the blood should start coming back up. Now, remember, all that fluid got sucked out of the cells, and the cells of the body need water in order to perform those chemical reactions. So in addition to insulin, you're going to have to give them IV fluid, and usually it's about 3 liters in the first 5 hours. So these people are really, really, really dehydrated. And the other thing, you have to be monitoring that potassium hourly when your insulin is given, because that's going to drive the potassium in the cell. And if that potassium drops too low, the heart's going to become irritable. They can go into ventricular fibrillation and die. So and again, look, if you understand the functions of insulin, what it does, then you don't have insulin. You should be able to predict what's going to go on. The other thing is that if you know the problem is caused by a lack of something, in this case lacking insulin, then the treatment is you give them insulin. See? All right, so watch. Once the blood sugar is under 200 and there's no ketones in the urine, you want to switch to a 5% dextrose. Dextrose is just the sugar that's found in corn, right? So it's glucose from corn. And a 0.45% sodium chloride. Now, so that's basically half normal saline. So what you want to do is you want to start being able to push the water back into the cells to rehydrate those cells. And remember, if you're giving an IV infusion of insulin and the blood sugar is under 200 and there's no ketones in the urine, you want to give them an IV of glucose, because you don't want them to go into hypoglycemia. Now you got all kinds of problems, right? And then you want to find out what caused it. Was it caused by illness, right? They have a heart attack, they have pneumonia, infection, or was it because they weren't taking their insulin properly, or potentially all three? So once you correct the ketoacidosis, you identify the cause, and that's diabetic ketoacidosis. Now, this hyperosmolar hyperglycemic state, to be honest, the name sounds more sinister than really what's going on. First of all, this type of situation is typically found in type 2 diabetics. Remember, in most cases, type 2 diabetics, insulin is not the problem. The problem is either insensitive insulin receptors. So because they have insulin, you're not going to develop that ketoacidosis that's seen in type 1 diabetics. However, they still can develop the same type of problems with the big high blood sugar and the fluid shifts. So one of the big problems too you got to remember is in the elderly, because they have a poor thirst reflex. If water's getting drawn out of their cells, even though they should be thirsty, they may not be, so that can lead to that hypovolemia problem. And then because they have insulin, they don't develop that ketosis or ketoacidosis. It's very rare, but they still got those fluid shifts, and they still have those big problems with electrolytes. So their problem basically is the fluid shifts and the electrolyte disturbances. So again, in many respects, the treatment for HHS and DKA are similar, right? You want the IV fluid replacement, similar to DKA. There really shouldn't be a need to monitor arterial blood gases unless they're really in trouble. Like there's a lot of extenuating circumstances that are causing the liver to start dumping acids into the blood. And then again, aggressive management and assessment of their electrolytes. The last thing you need them to do is go develop hypokalemia and go into ventricular fibrillation, and then insulin to lower the blood sugar. And again, you're losing all that fluid, right, along with the electrolytes, so the blood thickens up, and in some cases they will give like a Lovenox to prevent blood clotting until you can resuscitate them with IV fluids. So that's a basic overview, kind of an idea of DKA and HHS. I hope it helped, and I'll see you later.